kids were supposed to get a pediatric blood thinner named Hep-Lock, but instead they were given 2 doses of heparin, the adult version, 1,000 times stronger.
The nurse didn't bother to look at the dosage on the bottle. It was 10 units that our kids were supposed to get. They got 10,000, and what it did is it basically turned their blood to the consistency of water.
After undergoing extensive medical tests, today, both children show no signs of permanent damage. The Quades have created a foundation to raise awareness and address the problem of preventable human medical errors.
As a patient, you have rights. Look-alike, sound-alike drugs and other potential areas for mistakes and errors. Would you like to know if your nurse makes a mistake with your medications? This and other issues related to medication errors are discussed on this episode of the Real Nurses Talk Show. Let's get started. Sunshine, gonna make your day. Sunshine, gonna make your day. Sunshine, gonna make your day. Welcome to the Real Nurses Talk Show. Thank you for spending the next half hour with us. I am your host, Sonia Justice. Today we'll be discussing common medical errors and how we can prevent them. So if you have any doubts that this is a very relevant conversation to have, let me give you some statistics. According to the Journal of Patient Safety, up to 440,000 deaths a year are related to preventable errors. The show today, obviously, we're hoping it's going to contribute to the reduction of number of medical errors. We're going to discuss some of the type of medical errors that you'll find in the hospital. I am here with Wendy, Wendy Votroubek. You probably remember her from another show. She's a certified legal nurse consultant. And we will be talking to her about the medication errors because this is what she does for a living. So we're hoping the viewers can benefit from your experience today. Welcome, Wendy.
Yeah, thank you.
Wonderful. It's good to have you here today. Can you explain to us what a legal nurse consultant is? What do you do specifically, and how does it relate to our topic today?
Right. So I'm a legal nurse, and I work with attorneys on medical-related cases. So primarily medical malpractice, personal injury, and criminal defense.
Okay.
So if the attorney thinks that there has been negligence, they give me the medical records and I go through them.
Okay.
But I also feel like I'm wearing another hat, and that is as a clinical instructor in nursing.
Got it.
And so then drilling into my students' brain about medication errors and how we can prevent them.
Oh, that is awesome. That's really fantastic. So we will get into that part in a little bit. But if someone wanted to become a legal nurse consultant, you need to be certified, correct? So if someone wants to become a certified legal nurse consultant, what do they have to do?
There's a lot of ways that you can do it. There's different trainings, and you can either do it online or in person. And then you have to take a certification exam.
Got it. And then after that, you can start your own practice, start contacting lawyers and let them know you're available. Okay. Since it's your job to look for these errors, to come through chats and see if we have any medical errors, I just think you're like the ideal guest to be here. So thank you for coming. Yeah, and the fact that you're a clinical educator, right? So let's begin. We often hear the term sentinel events. We use things like adverse effects, serious effects, and we relate this to different types of errors that can happen that can potentially cause harm to a patient. So can you differentiate what those are for our audience, please?
Well, when a patient is damaged or potentially damaged, there's the thought that it can be life-threatening or lethal.
Correct.
And they would die, or serious and to have adverse effects, or minor.
Okay. Okay, so it's just going to depend on if it causes mortality, if it's serious enough that you stay longer in the hospital, or if it's minor that nothing happened, but there was an error in
Right.
that case?
And also in medical malpractice cases, there has to be damages.
Okay.
So
What do you mean?
a damages means that there had to have been something that caused the patient harm
Okay.
and is causing long-term issues with them,
Got it.
typically.
Got it. Got it. So we're talking about medications. One of the first things we learn in nursing school are the patient's rights to medications. Could we just throw them out there for our viewers? Some nursing students are watching this too, so it's always a good reminder.
Right. So it's the right patient, the right dose, the right route, and the time,
The right time.
and the administration.
And documentation is
Right,
the new one they
documentation.
added, right? So we may have a total of,
Correct.
okay. And what are the common types of medication errors that you have seen? Have you worked on any do you consider tort cases, or what are those?
Just medical
Just
malpractice. But what's really interesting is that in working with the students, I can see them when they're passing their medications to do the 3 safety checks.
Right.
And a
And
lot
what
of
are the 3 safety
the 3
checks?
safety checks is before you give it, and then as you are drawing the medication out, and then right before you give it.
To just double check that you have, you go through the
Right, it's the triple check.
Right. Okay. And then once you're done doing this, then when you go to the patient's room, there's also the checks to do to make sure you have
Correct.
the right patients and everything, right?
Correct.
And that's where some of the potential errors for mistakes can be mitigated with some of the technology we have now too, right?
Correct.
Okay.
Correct.
All right, so we'll discuss that in a little bit. But medical errors, though, are not limited to hospitals only, are they?
Oh no, they can be in the long-term care setting,
Okay.
and then also in the home, and
Okay.
also it can happen within the pharmacy itself.
Yeah, I was thinking that
The
too.
pharmacy can actually prescribe or
Or
fill
even
the
outpatient pharmacists too, right?
right. No, that's
Yeah.
what I'm talking about.
Okay.
Yeah.
Okay. Yeah, and a lot of people deal with this. Even if you don't go to the hospital, you go to a physician's office or a nurse practitioner's office, and you get prescription, and then you take it, and there's potential for error right
Correct.
before you get your medication. So, so for example, wrong medication can either be that you would prescribe the wrong medication for the actual disease that you have, or it could be that they prescribed the right one, but the patient received the wrong medication instead.
Or if they're allergic to a medication and they've
then
been
they
prescribed the
receive
medication that
right.
they're allergic to.
Oh, that would be awful, wouldn't it? Yeah. So, so what are the areas of double check then that we have to potentially, especially relate to emails and technology?
Right. With electronic medical records, one of the big pushes for that is to reduce medication errors.
Okay.
Because it's pretty easy to see that when orders are transcribed by hand, there's more of a chance that the person that is taking the orders off can read it wrong. And also you don't have the check as far as how all the medications that they're on interact with each other.
That's true. That's true. So it kind of helps. It comes up with that warning. And I've noticed that on just about every single chart, that patient's chart that I've worked with, at the hospitals that have, the electronic medical records. When you go in and you either ordering the medication or you're ready to give it, there's always some kind of warning that there's some kind of reaction with some other meds.
Right.
And the reactions could be minor. It could be something that we can say benefit outweighs harm.
Right.
But at least it tells you pause and think about what you're doing.
Right. It can also happen with the dosage.
Right. Exactly. Exactly. And you know what? Thank you for mentioning that. One thing we are doing now is we have the pumps setting like stop limits on them. So there's the hard stop and the soft stop. So when you get to a certain, like with the drips I give in ICU, when we get to a certain dose level, it tells you, do you really want to go past this dose? And you can go past that if you can override that. Usually we can, because if I'm getting to that point, my patient obviously needs it. And then when it gets to the hard stop, it's like, this is like potentially harmful. So, and that is really good for somebody that is, especially in a situation where you're potentially working with like 10 different drugs and it's really high stress and there's a lot going on with the patient. So it is good to have those checks in place on them.
Correct.
Okay, so we're talking about several drugs that we're going to talk about several drugs that sound alike and look alike, and we're going to have pictures on there for you guys to see. So an example of that would be something like
Tramadol or Toradol.
yeah, and that would be, I mean, how would that cause the problem if someone gets one versus the other?
Well, I mean, certain medications work a certain way, and when a physician is prescribing one of the medications, he has the total care plan in mind. And so it's medications that sound alike, but it's also medications that if it's not properly labeled, they could be giving a medication for the ear and the eyes or something like that.
Right. And I was thinking a really good example would be like the clonidine, and the clonidine is the generic name for catapres, which is an antihypertensive, versus giving clonopine, which is a psych med. So clonidine, clonopine, they sound so similar. It's potential. I mean, the potential for making a mistake is there because of the way the names sound and the way the names look.
Right.
So what can we do with names like that? Do we do like TallMAN letters? What do we do to?
Do we do what?
You know, they have what they call TallMAN letters. Like some of my drips, like dobutamine or dopamine, they would they'll put the BU in capital letters, so you know this is dobu versus
okay.
So they call that the TallMAN letter check. So when you're getting it, the name stands out to you. So that's one way that we are preventing it. What's another way?
Well, that's hopefully where the 3 checks come in.
Okay. So let me see.
I think one of the other medications that a potential error can happen is insulin, with all the different insulin types.
Oh my God, there's so many on there. Yeah. Then your Novolog, your Novolent, your Humulin, your Humalogs.
Right.
Oh gosh, you're so right about that. So there was a pharmacopoeia report that said that they found that 38% of all medication errors were done. I'll just throw out some statistics out there if it's okay. Like 38% of pharmacy of all medication errors were done by pharmacy technicians, and that makes sense, right? Because they deal with so many medications and they're the ones putting them together.
Right, so you're talking about outpatient primarily?
Even in the hospital too. I think they just looked at it as a group. And they're also saying that's followed by pharmacists who deal primarily with medications, like at 24%. But then we come behind that at 20% because we administer those medications. Yeah, so isn't that crazy?
Well, I mean, when you consider that it's happening to people that have exposure to medications, and unfortunately, we're only human, and so there are mistakes that can happen.
Right. So the other thing too that I know people have said we could do to kind of prevent those errors is if you put them in separate bins, so they are not close. Like if I go to the Pyxis and I'm going to dispense a medication,
so do you want to explain what a Pyxis is?
We'll show you all a picture of the Pyxis too. Yeah. So Pyxis is just a machine that automatically dispenses medication. It has, now they're really smart. They're linked to our emails, and so they have stops in it now. You have some medications you actually have to tell people, tell the machine why you're getting it, and that way it's forcing you to look at that drug a second time. And when the drawers open so you can get the medications, they have little bins in there. So the check we have for this right now is that they don't want you to put sound-alike medications in that same area, because that's another potential area for mistakes. So put them in different storage bins.
Right, and so one of the things though is that in long-term care, they have electronic medical records, but they may not have all those safety checks in place.
That's true. So what would they do?
Well,
just
I mean, some of those
checks,
patients are on their individual meds, but some of them are on what's called community medications, to where it's aspirin or Tylenol or vitamins.
I see. So it's a multi-vial, one bottle, and you take multi-doses out of it.
Correct.
Okay. Oh, wow. So some other medications I was going to show you pictures of. I'll just read them out so that when they're on the screen, you can see it, guys. It's like a phenobarbital versus pentobarbital. You see what it's the potential for error with that one. ampicillin versus amoxicillin. That's a very commonly used antibiotic. Hydroxyzine versus hydralazine. I mean, there's just so many. And there is an institute for safe medication practices. They have a website, and they have like a list of hundreds of those medications that sound alike, look alike. And so if you wanted to learn more about this, you can go to that website.
And, you know, one of the advantages now is the internet. So you hope that some people actually look up the medication that they're taking, but I know that not everybody does that.
And the other thing too that we always caution nurses to do, like sometimes I look at a medication that I'm not familiar with and I'm about to administer. A lot of places have like right there in the computer, I can just go to the references and I can click on the micromedics, which is one of the drug guides, and I can just look through it, and right there I can tell what the potential effects would be, what interactions would be, and we use that a lot when it comes to giving medications in your IV. And you can put multiple drugs on the same tubing. You want to make sure that it's not going to crystallize. If you put two that don't belong together and you shooting crystals into somebody's body, that would be really awful.
Right. So one of the things is that it's like the more that you talk about electronic medical records and what they can do, it makes sense as to why hospitals and nursing homes across the country have put such a push into becoming electronic, because one of the main things was safety. It was not only communication from one institution to the other, but what was really pushing it a lot was safety as well.
Right. And you mentioned communications. That's another potential area too for mistakes. So you were getting a verbal order from somebody, and then they threw the name of one of the sound-alike medications, and you write down the wrong one, and the patient potentially gets the wrong medication, right?
Right.
Yeah.
So one of the things I know what has happened is what's called medication reconciliation. So when a patient is admitted, or if they are moving from one place to another, they're going through the medications that they're on. So then hopefully we know that the medications from one facility or from one area to another, especially if you're in an outpatient setting going into the hospital itself.
And that continuity of care too.
Correct.
You're getting the medications that you went on when you were at home. And we really do try, you're right, we really do try to, when we reconcile those MAs, we try to make sure that the doses that are being ordered are the same doses that, especially for the chronic medications.
Correct.
Yeah, some would definitely change in the hospital depending on what your admitting diagnosis is, of course.
Right.
Yeah, and you may go home on different doses, and that's where teaching comes in.
Right. So one of my students today was saying that one of the facilities that she worked in, a woman was transferred to the long-term care from a hospital, and she had a cardboard box full of all of her medications that she had from home. And so
they do come in. No, you're not kidding. You're not kidding. They do come in sometimes. It just depends on how many meds the patients is on, but they do come with bags, sometimes filled with pills.
Right.
Yeah.
And so, I mean, when there's more than one brain, as in electronic, that's helping, it can help prevent errors.
That is so true, but then there's always that tendency to rely completely on electronics.
Correct.
And you don't want to do that.
Correct.
Too, because the machine is only as good as the information that's put into it. So you still have to make sure that what you're seeing on there is the patient's, those medications are appropriate for those diagnoses.
Correct.
Right?
Correct.
So those checks we still have to do, even though we have the electronic
appropriate
system.
for that sex.
Exactly.
If they're pregnant or not.
I know, right? Yeah. Order Pitocin for a guy would not be a good idea. Yeah, that would be a problem. Have you dealt, or anybody you know dealt with any kind of malpractice situation where that was related to medications?
Yes.
Can you share that with us?
A case that I just reviewed.
Like in great detail?
A nurse the physician wrote orders for pain medications.
Okay.
And unfortunately, the patient in question, her kidneys were not of the best condition, and neither was her liver. And unfortunately, the nurse gave the larger dose of the pain medication, and the patient had an adverse effect. She did not die, but there were problems.
Did they have to code this patient? Oh God. So what are you saying? One, I would need to explain this to people. One of the things that happens with pain medications is that you get respiratory depression. Some people are more sensitive than others, but depending on the higher the dose you get, the more your respirations get depressed. It's one of the things that it's supposed to do. It's supposed to, calm down your systems, really. So there is the potential that someone can eventually quit breathing if they keep getting pain medicine, like continuously, and you're not monitoring them. And that's when you get to a situation where you have to code somebody, where you have to resuscitate them. And that's what you're saying happened to this patient. They didn't die, but they had that serious effect happen, which you mentioned earlier. So when they left the hospital, they contacted a lawyer then?
I don't really want to say anything more, but
because it's a case that you're working on?
But you can understand, if somebody is in significant pain, your response is that you want to help get rid of that pain, but it's also our responsibility to look at the full patient and to figure out which dose is the best.
Absolutely. And sometimes we have patients that will come in and say, oh, I'm hurting, what's your pain? It's a 1 out of 10, on a scale of 1 out of 10, and they tell you, oh, it's a 10. And then you get to the door, they fall asleep. It won't be a good idea to give that patient that medication, especially not the higher dose, because if the pain was that high, chances are they will not be falling right back to sleep on you. And you want to constantly check their respirations and their saturation. So let's see, what about medication errors that people can make at home, like not being compliant? That is a potential medication error right there, right?
Right, absolutely. If, for example, if they go to the doctor and say that they've been taking their medication and there's not any problem, but they haven't been, and then the physician's decision is based on the information that they're given.
And then even like with something antibiotics, if you don't take in enough and then you become resistant later. So that's a huge deal. Do you think hospital staff should disclose to patient and family if there's an error that's occurred?
That's a really good question.
Yeah.
I don't know what the answer to that. What I do know is that in the past, and I think previous generations, people felt really shamed when there were medication errors. And I think that what's happening now is that the whole feeling within a hospital is that if there is an error, that come forward and maybe there's a processes within the hospital that we need to address.
That's true. That's true. And that's where ethics do fall in, and the need for transparency. Patients will always, I'm sure patients will say, I want to know. So that there is that need for transparency.
I don't know if all errors that happen, the patient is aware of.
Right, right.
But I do know that hopefully what's happening is that within the hospital, at least the hospital is able to change systems as need be to prevent further errors.
Right. And so if you work in an environment that's not punitive, the likelihood of you sharing the fact that you've made a mistake is higher, and that can become a learning experience for everybody. So, but if they think they're going to lose their job, that's when people are afraid to disclose information. So you do not want your staff to work in an environment where they feel they cannot come to the authority, or they cannot go to their co-workers for help, right? Yeah. Well, I'm being told that we are running out of time, so that's it for our show today. Medical errors directly impact a patient's outcome in a hospital. You can end up with a serious adverse effect, like the patient you mentioned earlier, the one that ended up having to be resuscitated. And it also, and you can stay longer in the hospital. And all these things end up affecting not just the patient's health and well-being, but it also affects profitability of that hospital. So it is imperative that we try to cut down on this, and I'm glad that we're heading in that direction. That's on the forefront of everybody's mind. I am your host, Sonia Justice, and I'll be signing up. Thank you for spending this half hour with us, and bye-bye. See you on Facebook.